presumptive possibilities. We are saying that its recurrence rate is 25%. We are speaking about percentages and the decision to the patient to do prenatal diagnosis or not. If we look to the post-diagnostic counseling, it's quite different because we are explaining definitive results. We are speaking about negative or positive and the decision to continue pregnancy or not. The decision making. Obstetricians working in the field of prenatal diagnosis should be aware about the scientific, psychological, and ethical aspects of each disease patient condition. Considering collectively these aspects in the decision making is mandatory because they are closely interrelated and affecting each other. Looking separately to any aspect without considering the others is disadvantageous and maybe disastrous. Counseling is a dynamic and non-dogmatic process helping couples decision making and not doctors decision imposing. What is the importance of early prenatal diagnosis? As we have already said, chorionic villus sampling done at 11 to 12 weeks gestational age will provide early diagnosis and consequently giving the patient the option and opportunity of an early termination which is medically safer. Also from Islamic perspective, ensoulment of fetus from Islamic perspective, many Muslims believe that the soul comes after the first 4 months, 120 days of pregnancy. So if termination is to be done, it should be in that gestational period. I'm always looking to any ethical puzzle as tripolar: society, patient, and doctor. In any medical issue with an ethical aspect, there is what I call the ethical puzzle. We should consider and respect every side. We should avoid conflicts of interests between them. Obstetricians offering prenatal diagnosis bear a heavy responsibility. Diagnostic errors may result in loss of normal pregnancies or the avoidable birth of affected children. Obstetricians must be aware of the tests available so that they can counsel their patients accordingly. Our duty and responsibility as doctors, counselors, is to offer all the available options to our patients and couples. This is a picture of the King Akhenaten with his beloved wife Nefertiti and playing with their children. I'm hoping that every family will be like the king and the queen with happy children. Thank you very much.
Thank you, Professor Abu Nasr, for your nice, informative, marvelous presentation, and we will leave discussion for the end of the session. And now we will invite Professor Malman. He's a German professor interested in gynecologic oncology. He is coming over the seas to address to you a very interesting hot subject, which is conservative and operative treatment of endometrial hyperplasia and endometrial cancer. And now we are going to listen to him.
We have to change it.
Sabah al-Khair, ladies and gentlemen, dear colleagues. First of all, I would like to thank the organizers to invite me to this wonderful congress at this wonderful place. I would like to present you some data concerning the treatment of endometrium diseases Of course, I know that there are some differences compared to our system in Germany and the Western countries, and in the beginning I would like to explain you some of these differences. In Germany and in some of the Western countries, we have guidelines for all diseases of female cancers. Guidelines mean that all societies which are participated in the treatment of female cancers come together. For example, for endometrial cancer, 75 societies, radiotherapy, pathology, medical oncology are coming together, and they analyze the literature, and then they finalize these statements. So, for example, we have analyzed all databases which are suitable for the disease of endometrium cancer, and at the end, more than 5,000 papers have been analyzed, and then a consensus meeting is organized, and the treatment has to be finalized in a consent. And these consents I would like to present you, and I have prepared some cases to explain you how we treat these cases worldwide. The first case is a routine case in the daily practice. You have, for example, 57-year-old woman with a persistent bleeding, and she comes to you in your office and wants a treatment. You will start as a first step with a vaginal ultrasound, and you can see, for example, this finding. This is a normal endometrium. It seems to be atrophic, and you don't find anything which is pathologic. In this case, the first discussion in this consensus meeting was, is it really necessary to perform a D&C in this situation? Because in most cases of this ultrasound finding of an atrophic endometrium, you will find just this, which I show you in this hysteroscopy finding. You will see nothing. And the first statement is that in all cases of a bleeding disorder, it is necessary to perform a D&C, because independently of the findings of the ultrasound examination, even in cases of atrophic endometrium, we cannot exclude that this is based on an endometrial cancer. Of course, the ultrasound has a great importance for the diagnosis of endometrial disease. For example, this case is a hyperplasia, and if you perform a hysteroscopy, you can confirm this ultrasound diagnosis of an endometrial hyperplasia. You can detect polyps, and of course you can detect endometrial cancer. In some of these cases you perform Doppler ultrasound and you can see the disease. We have performed a big discussion whether ultrasound examination should be done routinely in all women to exclude endometrial cancer as a screening method. The international literature is completely convincingly. More than 100,000 women have been examined in several studies, and the results are always the same. The sensitivity and the specificity of ultrasound to exclude endometrial disease is very high. But in all studies, no reduction of mortality has been observed. In the opposite, an increase in morbidity was observed, because a lot of women has to undergo a D&C due to the findings of the ultrasound examination, and at the end there were no pathologic finding. So, following our consent, there is no indication for routine ultrasound for the early detection of endometrial cancer. We have confirmed this consensus in our hospital. We have analyzed all those women which were sent to us due to pathologic finding of the ultrasound examination, and as you see, most of them have benign diseases. 299 of these 304 women underwent a D&C without any pathologic finding, so this operation was not necessary. I come back to this women. We perform a D&C, and we combine the D&C with the hysteroscopy, and we don't react on the result of the ultrasound. So this is the first consensus statement of this consensus conference. Screening cannot be recommended. There's no reduction in mortality even in a high-risk population if you perform ultrasound. So, next case, a 37-year-old woman, no pregnancy, she's coming with bleeding disorders in several months. You perform a DNC, and the result is she has got an atypic endometrial hyperplasia. Of course, you can perform a hysterectomy, but in this young woman, no pregnancy, she wants to get pregnant. And there we have analyzed the literature, and an endocrine therapy can be performed using either MPA or using begestrol acetate over 3 months. Then you have to perform another DNC, and if there's no pathologic finding, she can get pregnant, but in all cases we recommend to perform the hysterectomy after delivery. The next case is the typical situation of a postmenopausal bleeding. You perform a DNC and you get the result of the pathologic examination, and she has got an endometrial cancer. You know this woman will need an hysterectomy, but of course several questions has to be answered. First of all, which kind of surgery? Can you do it by laparoscopy or can you do it by laparoscopy? Does this patient need lymphadenectomy? And of course, what will be the further treatment? I'll start with the first question, laparotomy or laparoscopy. You all know the advantages of laparoscopy, and of course you are afraid that this technique may lead to any disadvantage for this woman, maybe a spread of tumor cells, maybe it's something else. And we have analyzed the literature, and the question, does a laparoscopy really increases the oncologic risk of endometrial cancer, can be answered with a clear no. In all studies, there were no differences concerning the overall survival, so you can perform your hysterectomy by a normal vaginal approach or an approach using laparoscopy. Using laparoscopy, most of us prefer to use a manipulator which makes the hysterectomy much easier. Some of us are afraid that using this manipulator we would increase the oncologic risk, we would lead to a spread of tumor cells into the vagina, and this question has been examined in several studies, and following the meta-analysis of these studies we can answer the use of these manipulators will not increase the risk of recurrences. The next question is, we have decided to perform the operation by a vaginal approach or by laparoscopy, but you don't know which kind of hysterectomy you have to do. You have got the result of the DNC, and in the pathology they found that the tumor cells can be found in the carbon-uterine and in the cervix, and some of you believe in these cases of a participation of the cervix we need to perform a radical hysterectomy, the so-called Wertheim approach, where we resect the perimetrium too. We have analyzed the literature, and in these cases there are no data that there's any advantage to perform a radical hysterectomy. So you can treat all kinds of endometrium cancer, even these patients with a myometrial invasion, with a simple hysterectomy. There's no need, no indication to perform a Wertheim operation in these cases. So the consensus of the international literature, which kind of treatment for an endometrial cancer, which has been proven by a DNC, is you should start with the peritoneal hysterectomy, and of course you have removed the both ovaries and saplings. And the next question is, what's about the lymphadenectomy? In most cases of endometrial cancer, it's not necessary to remove the lymph nodes. In all these cases where the infiltration of the cancer is limited on the inner part of the myometrium, less than 50%, you just have to perform a simple hysterectomy, nothing else. The data are convincingly performing lymphadenectomy does not improve the survival. The prognosis in these cases of endometrial cancer patients is so good that you will not be able to improve it by any other surgical approach. But by the resection of lymph nodes, you will increase the morbidity significantly, and this leads to this other statement: only in tumors with a higher oncologic risk, this will mean a deeper myometrial infiltration or an differentiated cancer, and in some special histology you have to perform combined lymphadenectomy in the pelvic and the parietal region, but in all other cases it's not necessary. Coming back to this patient, we have performed the operation, we have performed a simple hysterectomy, and we have performed a lymphadenectomy because the infiltration was deeper and she has got one lymph node metastasis. In this situation, I know that the organization of oncology in Egypt is quite different. You will send them to your medical oncologist, and of course the patient will ask you to your opinion. Therefore, you allow me that I will show you which will be the further treatment. We have three opportunities. You can do nothing, you can perform a chemotherapy, and you can perform a radiotherapy, and of course you can do everything. What is the adjuvant treatment? What are the data? The half of all patients with endometrial cancer don't need any further therapy. They are successfully treated by your hysterectomy. These are all stages where the infiltration is less than the inner half of the myometrium. There's 1/3 of patients which have an increased risk. For example, this from the grading, for example, the myometrial infiltration is more than 50%, and these patients need radiotherapy. Unfortunately, a lot of women worldwide get a combined radiotherapy. This will mean an afterloading in the vagina and an external beam radiotherapy. We have analyzed the literature, and this is only one study of many, where the patients have been randomized getting an external beam radiotherapy or only an afterloading in the vagina, and the results are convincingly. There's no difference between the complete radiotherapy and only a local therapy in the vagina, no difference concerning the overall survival, and which is very disappointing, there is a difference if this treatment is done in younger patients. In patients who are getting this combined radiotherapy, the risk of getting secondary cancer is dramatically increased. They are getting much more cancers in those cases where we have performed an external beam radiotherapy, and this leads to the consequence there is no indication for an external beam radiotherapy. There's only an indication for local radiotherapy of the vagina. This leads to reduction of the risk of local recurrences, but not more. And then I come to the last part of all our patients, approximately 20%. These patients, for example, with node-positive cancers, they have a high risk of getting a relapse, and this risk can only be reduced by performing a chemotherapy, for example, with carboplatin and paclitaxel. Using chemotherapy, which is quite uncommon because in most cases even oncologists believe that this disease can only be treated by operation and radiotherapy, but there are convincing data that chemotherapy is also a good approach. As you can see here, using adjuvant chemotherapy in high-risk endometrial cancer will lead to reduction of the progression-free survival and the overall survival. So I would like to convince you about the news in the therapy of endometrial cancer. First of all, in spite of the organization of oncology in your country, you are the first part and the most important part for the treatment of this disease. remember that we can use some method, for example, ultrasound, to get further information, but the most important step is that every bleeding disorder, bleeding disorder must be examined by using a DNC. Ultrasound may be helpful, but it cannot exclude patients which don't need a DNC. If the treatment should start, the patient can be kept in your hands. If she has an hyperplasia, you have the possibilities of a treatment with endocrine methods. If it is an endometrial cancer, you should perform the surgery. It does not matter which kind of surgery you prefer. You can do it conventionally by a laparotomy. You can use a vaginal approach. You can do laparoscopy. From the oncologic point of view, the three approaches are similar. There is no indication for a Wertheim operation, though you don't need to send this patient to a gynecologic oncologist to perform a Wertheim operation. In some cases where you get the information of a deeper myometrial infiltration, you need to perform a lymphadenectomy. The adjuvant chemotherapy is indicated in certain cases of high risk, for example, all node-positive patients, and take care that your patients will only get a local radiotherapy in the vagina. There is no need for performing an external beam radiation. As I have shown you, even this leads to a disadvantage for the patient, as it will increase the risk of further cancers in their life. This is what I want to tell you for this disease. Thank you very much for your attention.
Thank you, Professor Peter Malmann, Cologne University, Germany, for your up-to-date and directed presentation, and we hope to be with us every year, and welcome. And now we shift to the next presentation. Dr. Yaqub Khalaf, Gage Thomas Hospital, London. Welcome, Dr. Yaqub. He will address you commercialization of IVF. Whose interest are we serving?
Can you get the phone, please? Yeah, this one. Yeah.
Okay, good morning, ladies and gentlemen. Mr. Chairman, I would like to start by thanking the organizing committee, Professor Abu Nasr and Professor Zakaria, for their kind invitation and to be here among friends and colleagues in Cairo University Conference. Our field, people may appreciate this or not, touches people's life and touch their emotions and touch their pockets, sadly. And IVF, when it was first invented, I don't think Edward and Steptoe had money in their mind when they invented IVF. They were trying to help and alleviate the suffering of those who were not having the blessing of a child. Infertility is not something to be undermined. In every holy book, there will be reference to infertility. And some women, whether it is in the old days or in the current days, would probably think that their lives are not worth living if they don't have a child. And this quote from the Bible, which said, "Give me a child," or "Give me children, or else I die." So it's not something that is very simple or very easy for couples who don't have a child. And although some people think that infertility never killed anybody, and as such it is a condition perhaps, or it is some lifestyle issue, but the WHO eventually acknowledged that infertility is a disease. It is not something to be undermined. And for those of us who are blessed with having children, It's probably important to step in the shoes of the couples who don't have children, and perhaps then one would appreciate the suffering that they go through. And there are so many people who are getting on with their lives with big smile, true smile, fake smile, but unfortunately it does not hide the suffering internally because of this loss. Added to this, the stress that infertility causes to the couple themselves, to their relationship, and to their general well-being. And money is central, unfortunately, in the business of infertility. Whether it is done wisely or otherwise, still there are costs attached to it. And the costs sometimes are very expensive. And funding of IVF is challenging to countries where they have much healthier economy than we have here in Egypt. And you can see the variation in the level of funding of IVF in different European countries. And I'm afraid even the UK or England, the coverage of IVF funding is not something to be proud of, because only 40% are funded by the state and 60% have to dig deeper into their pocket to pay for treatment. Try to spare a thought for our not particularly fantastic economy and our not particularly great Egyptian pound. You can see how much it would be costing the couple to undergo treatment. And gradually, the business of IVF has become not just medicine, but it was a combination, and sometimes it is a whole unholy combination of money and medicine. And this has left patients are unsure and puzzled and lost and baffled and sometimes manipulated, sometimes exploited, and that is important to remember. The Independent newspaper was having like a separate issue about the IVF business. And it is fair to say the business of IVF is not restricted to a particular country or a particular community. It is global. And there are people who will give precedence to business and greed, and there are people who will do medicine with sound ethics. In the United Kingdom, there is a big function called the Fertility Show, where there will be 3,000 couples under one roof every year, and every assisted conception unit in the country will have a stand to try to market their services and share the information with patients. All kind of advertisement is happening, where you find so many clinics advertising whatever you want, we have it. You want to check the gender or the sex of the baby, we can give you that. You don't have eggs, we can give you that. You don't have sperm, we can sort this out for you, and so on and so forth. And when you go to the supermarket, it might tell you that you get one thing, you get the other free. Unfortunately, this is spreading to IVF now, where you have 3 cycles for one package. And there are some clinics which will give you guarantee. If you don't have a baby, you take your money back. So you can see how we are progressing with the business of IVF. And it gets even silly, where there are some competition where you have a draw or a lottery, and the prize for this is to have a free cycle of IVF. It is becoming really from a tragedy to a farcical comedy. Now, the list goes on, and the commercial surrogacy is rife in different parts of the world, mostly Southeast Asia. And even in the United Kingdom, people who don't have the money may have to go abroad in order to have their treatment, and depends which country you would like to go and how much money you have. I will move on to the bit of practice after covering this global issue that we have. One of the most